So now we'll be dealing with approach to a patient with limb injury. So first thing you have to ascertain is whether there is a fracture, and if there is a fracture, is it closed or open? Is it a traumatic or a pathological fracture? And are there any complications associated with it? So first you have to start with clinical examination. It is important to decide whether an X-ray is needed because it is especially relevant if the person has to travel far away to get an X-ray. And then you also need to ascertain whether the injury needs a special view. Mostly you take AP and lateral views, but sometimes some X-rays they need a special view. For example, scaphoid fracture, you should take an oblique view of the wrist. Okay, and also you always need to correlate clinically, right, any radiological finding. So that is because you can find out certain artifacts, and you can avoid mistaking them for fractures on an X-ray. And also you can detect complications associated with the fracture, such as injury to the neurovascular bundle. So that is why a thorough clinical examination must precede an X-ray in all cases of musculoskeletal injury. So first, the question you have to ask yourself is there a fracture? So again, based on history, so based on the age of a patient, so fractures occur at all ages, but dislocations are uncommon in children. Okay, so that is one thing you need to remember. So at birth, so clavicle and humerus, they're fractured. In children, especially upper limb, so supracondylar fracture of the humerus, that is common. In adults, fracture of shafts of the long bones when they fall or something. And in elderly people, Colles fracture and fracture neck of the femur are common. Okay, so that is one thing you need to keep in mind. And then the mechanism of injury. So the mechanism by which the patient sustains the injury often gives an idea of about the expected fracture or dislocation. So if a person falls from some height onto the heels, you can expect a fracture of the calcaneum, lumbar vertebrae as well, and a fracture of the pubic rami. So fall on an outstretched hand, again fracture clavicle, fractures around the elbow, all of them they happen like this. Flexion extension injuries, fall with so spine injury mechanisms. And again, slipping in the bathroom, so trivial trauma, fractures neck of the femur, especially this happens in the elderly. Okay, and again dashboard injury, so you're hitting the dashboard, so your hip goes posteriorly, so the posterior dislocation of the hip. Fall onto the heel, so fracture calcaneum, we already discussed this. Hit by a stick, so fracture ulna, things like that. Next, presenting complaints. So again, patient presents with pain, and the severity of pain has no bearing on the diagnosis. So sprains and strains also can be as painful as a fracture. So you'll have pain, you'll have swelling, you'll have a deformity. Okay, of any fracture, it can result in a deformity of that part of the body, and also there is a loss of function. Okay, swelling, it may be slight if the patient presents immediately after the injury, but in those swelling presenting late, the whole limb may be swollen because of passive gravitational edema. So examination. So basically, what do you see on examination? So you will see a swelling. So most fractures are accompanied by swelling at the site. So this may be misleading because in fracture neck of the femur, even though it is a serious fracture, you'll have minimal swelling. But on the other hand, in cases of ligament sprain and muscle injuries, even though there is no fracture, you'll have a lot of swelling. Swelling may be due to hematoma, or because of prominence of the bone ends, or because of any passive gravitational edema. Then deformity. It is a very specific sign of a fracture or dislocation. So sometimes just by looking at the deformity, you can find out a fracture. So example, if there is flattening of the shoulder, you can diagnose anterior shoulder dislocation. Okay, so dinner fork deformity in Colles fracture, that is classic. So mallet finger, so avulsion of the insertion of the extensor tendon. So the extensor is avulsed from the distal phalanx, so you'll have a mallet finger. Next, flexion, adduction, and internal rotation. So if this is my right leg, so flexion, adduction, and internal rotation. Okay, everything is going towards the midline. So there is posterior dislocation of the hip that happens there. So exact opposite, so abduction and external rotation, anterior dislocation of the hip. So external rotation of the leg, it happens in fracture neck of the femur and trochanteric fracture. Then again, you'll have swelling, and pain again you elicited by using pressure, so that is tenderness. So you can apply direct and indirect pressure for the tenderness. So basically, in direct pressure, what you do is you go with the back of the thumb and you keep palpating the surface of the bone. At the site of maximum tenderness, you can find out a fracture. And the site of maximum tenderness, it also helps in differentiating ligament injuries from that of fractures around a joint. Okay, you can also feel or hear a crepitus while eliciting tenderness directly. And indirect pressure, you have some maneuvers, like for example, springing test. So in a fracture of the forearm bones, when you press both the bones together, okay, so that also elicits tenderness, and axial pressure as well. So an axial pressure along the second metacarpal may elicit pain in the scaphoid fossa in case of a scaphoid fracture. Okay, so axial pressure just elicit some pressure, you will find pain in the scaphoid fossa. Next, bony irregularities as well. So you'll find that when you're palpating, abnormal motility. So that is one very important sign. So if one can elicit mobility at sites other than the joints or an abnormal range of movement at a joint, a fracture or dislocation is definite. Okay, you can hear or feel a crepitus while doing this. And there's also an absence of transmitted movement. So normally if a bone is moved by holding at one end, the movement can be felt at the other end. This transmitted movement will be absent in case of a displaced fracture. Okay, then after finding out whether there is a fracture or not, you have to find out whether it is open or not. So if there is a wound in the vicinity of the fracture, you need to find out whether the fracture is communicating with the wound. Okay, so you have to examine the wound under aseptic conditions. Okay, so it should be ascertained whether the compounding is from inside or from the outside, so internally open or externally open fracture. Next, is it a pathological fracture? So it must be suspected. See, if the force producing the fracture is insignificant, okay, if there is very little trauma but the fracture is there, so again that could be a pathological fracture. If there's a history of pain or swelling before the occurrence of the fracture, if there is history of frequent fractures, okay, in cases like osteogenesis imperfecta, and if the patient is suffering from a debilitating systemic illness known to weaken the bones like rheumatoid arthritis. So rheumatoid arthritis, it weakens the bones. Systemic illness, osteogenesis imperfecta, frequent fractures, history of pain and swelling before a fracture even occurs, and even if minor injury causes a big fracture, so that again suggests pathological fracture. And also you have to look for any associated complications. Then radiological examination, so it helps in diagnosis. So one thing, it can help you in diagnosis, evaluate any displacements, and study the nature of a force causing the fracture. So you ask for an X-ray, and before asking for an X-ray, you need to keep the following points in mind. So at least you need to take 2 views, AP and lateral, and you also need to take special views when necessary. So special views, some of them are oblique view of the wrist for scaphoid fractures, Judeth's view for acetabular fractures. Okay, acetabular, Judeth's view, Merchant's view for patellofemoral joint, and skyline view for calcaneum fracture. Okay, so then special views and joint above and below should be included in the X-ray, and X-ray requisition must specify the area for suspicion. For example, if there's a spinal injury, you can't just say take an X-ray of the entire spine, right? So you have to say focusing D12 or something like that. And X-ray of the pelvis with both hips should be asked for in all cases of pelvic injury. Okay, both hips. And for X-ray evaluation of the hands and feet, AP and oblique views are required. Okay, not lateral, AP and oblique views. So reading an X-ray, which bone is affected, which part, all that. All right, so you know how to read an X-ray. So basically, which bone is affected, which part, is it shaft or epiphysis or something? What level is the fracture, upper, middle or lower third? What is the pattern, whether it is transverse, whether it is oblique, is it displaced or not, which direction, is there a tilt, is there a shift, etc. If the fracture line is extending into the joint, and does it appear pathological, is there a cyst, is there an abnormal texture of the bone, and is it a fresh or an old fracture? So X-ray of a fresh fracture will show soft tissue shadow because of the hematoma, and the fracture ends are sharp. An old fracture will show callus formation and diffuse osteoporosis, and the fracture ends are smoothened. So X-ray findings, they should always be correlated clinically. Okay, and you also can misinterpret some things for a fracture, and these things include epiphyseal lines, vascular markings on the bones, accessory bones, etc., and you always compare it with the other limb. So fractures which are commonly missed include greater tuberosity. So in AP view of the shoulder, fracture of the greater tuberosity is missed as it gets displaced behind the head of the humerus. Then acromioclavicular joint subluxation, so AC joint, greater tuberosity, posterior dislocation of the shoulder. If it goes posteriorly, again you can't. And capitulum and scaphoid, so that is why you need an oblique view. Okay, so in lower limb you have acetabulum, patella, all these things, so just keep them in mind. So again, old fracture. So after 2 to 3 weeks, you'll have signs of a fresh fracture like pain, soft tissue swelling, tenderness, etc. You'll find them diminishing. On X-ray examination, the fracture ends will appear smooth. Okay, they'll not be sharp, and a callus will also be present. They'll appear smooth because healing is taking place. So when a patient with fracture presents late after the injury, you need to ascertain whether the position is acceptable or not, and at what stage of union it is. Is it at the stage of delayed or non-union or malunion, like that. And approach for polytrauma patient. Okay, before discussing this, let's just discuss the approach for a patient with limb injury. So first, is it a fracture? Okay, if it is a fracture, is it a closed or open fracture? Is it a pathological or traumatic fracture? And is there any neurological deficit? So first, think of these questions, give first aid, and go for an X-ray. If the fracture is not obvious, trace all the cortexes of the bone visible, cortices. Okay, if there is no fracture, you'll go for conservative treatment. If there is a fracture, and even if on x-ray the fracture is obvious, think of the other questions and go for treatment. And if there is no fracture, go for first aid, x-ray. And if there is no fracture, think of which soft tissues could be injured. Is it a sprain of a ligament or strain of a muscle or skin contusion? So look for a subcutaneous hematoma in case of a contusion, drain it, and advise rest. And then if it's a muscle strain, so find out whether it is partial or complete and treat it accordingly. If it's a ligament sprain, so what degree, first degree, second degree, or third degree, and treat it accordingly. Okay, one thing you need in a polytrauma approach is field triage. So ideally the management of multiple injured should begin at the scene of the accident. Okay, so he should be able to provide a basic life support, and the person should also be able to help in transportation, and he should be able to ascertain which injury is serious, who needs to be transported immediately to the hospital, etc. So that is the primary survey. So this constitutes, especially in the emergency department, once the patient reaches, you'll start with the primary survey. So there is rapid assessment of airway, breathing, and circulation, so the ABCs. So again, resuscitation as well, and then that is followed by the secondary survey. So you will do a proper neurological exam, thoracoabdominal assessment, genitourinary and musculoskeletal assessment. Okay, so musculoskeletal assessment is not high on priority. So the only injuries related which are important at this stage are vascular injuries. So you check all the peripheral pulses and the circulation, nerve injuries, okay, and any dislocation or subluxation. They need to be treated early. Other things, they can take, other important things can take precedence before them. Then definitive treatment, again, you will think of whether the fracture needs internal fixation or not. The current trend is to internally fix as many fractures as possible in a polytrauma patient, often in one sitting. Okay, this has resulted in decrease in morbidity and mortality.